Transient Ischemic Attack, aka TIA. It's often called a warning stroke or mini stroke, and it's a medical emergency. Why? Because 5 to 10% of TIA patients will have a full stroke within 2 days, and 10 to 20% within 3 months. This is preventable with urgent evaluation and treatment. So, what exactly is a TIA? As in the name, a TIA is a transient episode of neurological dysfunction caused by focal brain, spinal cord, or retinal ischemia. But here's the key. There's no acute infarction on imaging. Classically, symptoms last less than 24 hours. But in reality, most TIA cases resolve within 1 hour. The modern definition is tissue-based. If there's no infarction on MRI, it's the TIA, regardless of symptom duration. Okay, the most important thing to remember, TIA is a warning sign. It tells us a stroke is coming and we need to act fast to prevent it. The causes of TIA are the same as ischemic stroke. We have atrial TIA from carotid stenosis or large vessel disease. We have cardioembolic TIA, most commonly from AFib. Also, small vessel disease can cause lacuna TIAs. And there are other causes, like arterial dissection and hypercoagulable states. Risk factors include hypertension, AFib, diabetes, smoking, advanced age, and hyperlipidemia. The hallmark of TIA is sudden onset of focal neurological deficits that completely resolve. In anterior circulation TIA, you might see hemiparesis or hemianesthesia, aphasia if the dominant hemisphere is affected, or monocular vision loss called amaurosis fugax, which patients describe as a curtain coming down over one eye. In posterior TIA, symptoms include vertigo, ataxia, diplopia, dysarthria, or bilateral and cross deficits. Remember, sudden onset and complete resolution. If symptoms persist, it's not a TIA, it's a stroke. Okay, let's talk about the workup. First, imaging. A CT scan is your first line to rule out hemorrhage and stroke mimics. But the best test is MRI with diffusion-weighted imaging, which is very sensitive for detecting acute infarction. Interestingly, 30 to 50% of patients diagnosed clinically with TIA actually have small infarcts on MRI, meaning they technically had a stroke. You also need vascular imaging with CT angiography or MR angiography or carotid ultrasound to identify stenosis, which is critical for treatment decisions. Now for labs, immediate priority is checking serum glucose to rule out hypoglycemia, DKA, or HHS, which can mimic TIA. You also need a CBC and a lipid panel and other basic labs. Cardiac evaluation is essential. Get an ECG to look for AFib. Consider continuous cardiac monitoring for at least 24 to 48 hours to catch paroxysmal AFib. And get an echocardiogram, either transthoracic or transesophageal, to identify cardioembolic sources like left atrial thrombus, valvular disease, or patent foramen ovale. To stratify stroke risk after TIA, we use the ABCD2 score. This score has 5 components. A is for age, 60 or older, which gives 1 point. B is for blood pressure, 140/90 or higher, also 1 point. C is for clinical features. Unilateral weakness gives 2 points. Speech disturbance without weakness gives 1 point. The first D is for duration. Symptoms lasting 60 minutes or longer give 2 points, and 10 to 59 minutes gives 1 point. The second D is for diabetes, which is 1 point. The total score ranges from 0 to 7. A score of 0 to 3 is low risk, with about 1% stroke risk at 2 days. A score of 4 to 5 is moderate risk, with 4% stroke risk at 2 days. And a score of 6 to 7 is high risk, with 8% stroke risk at 2 days. High-risk patients should be admitted. This includes anyone with ABCD2 score of 4 or higher, carotid stenosis more than 50%, AFib, or symptoms within the last 3 days or 72 hours. Treatment should start immediately. For high-risk TIA, we use dual antiplatelet therapy, aspirin plus clopidogrel for 21 days, then continue with a single agent. This approach reduces early stroke risk by 30 to 40%. For lower-risk TIA, you can start with single antiplatelet therapy, either aspirin or clopidogrel. All patients should also start a high-intensity statin immediately, like atorvastatin AT. If the patient has AFib or another cardioembolic source, start anticoagulation, but typically after 2 weeks to avoid hemorrhagic transformation. Drugs are preferred over warfarin. Do not lower blood pressure acutely, as this can worsen ischemia. Start or restart antihypertensive after 24 to 48 hours. Secondary prevention for TIA is the same as for ischemic stroke. Continue antiplatelet therapy with aspirin or clopidogrel for non-cardioembolic TIA or anticoagulation with drugs for AFib. Use high-intensity statins with a target LDL below 70. Control blood pressure with a target below 140/90, preferably using an ACE inhibitor or ARB. Manage diabetes with a target HbA1c below 7%. And of course, lifestyle modifications, smoking cessation, regular exercise, healthy diet, and weight loss. If the patient has symptomatic carotid stenosis of 70% or more, they need carotid revascularization within 2 weeks. This can be done with carotid endarterectomy or carotid artery stenting. Early intervention significantly reduces stroke risk. And that's TIA in a nutshell. Thank you for watching. If you found this helpful, please like, subscribe, and hit the notification bell. I'll see you in the next video.